Hello, I'm David Price. I'm from the University of Aberdeen and the Observational and Pragmatic Research Institute in Singapore and Optimum Patient Care, Australia and the UK. And I'm delighted to be discussing with you today the changes in the GINA asthma management strategy and what that practically means to us. Here's my disclosures, and you can see, I think, most companies involved in respiratory medicine. So I'd like to discuss four key themes with you today. The first is the concept of ICS formoterol controller and reliever therapy across all asthma severities. I'd also then like to discuss the patients in whom that's not suitable and the classical GINA treatment track too. And then finally, I'd really like to focus in on some of the particular challenges between primary and secondary care and the importance of assessment of our patients with asthma and the need for referral of appropriate patients. And finally, a little challenging teaser of a potential new treatment paradigm. So if we like to think about this new strategy of ICS formoterol control and reliever for all severities, so this is really quite a novel statement. We've already had for many years the concept of maintenance and reliever therapy for those with ICS formoterol from step 3 upwards. But now there's an introduction of as needed low dose ICS formoterol for the milder patients. The idea it could be just used as needed rather than as a regular treatment. So this is quite a radical step forward. And I'd like to look at just very briefly at some of the evidence and why that's been suggested. And the main concepts behind it is that the evidence of reduced risk of severe exacerbations versus SABA alone, the challenge for many patients of poor adherence, and the idea that maybe we don't always have to solve that problem for our milder asthma patients. A big one, though, is the ability to reduce OCS use and associated side effects. And finally, I think a very important educational one, that if we give patients SABA as needed as their first therapy, when then we tell, and they feel that works, then we tell you, well, actually, you shouldn't take that all the time. We really want you to take something else. That's a very confusing message. And so what do we know about SABA and its association with bad outcomes? Because that's the big driver here. Well, there's lots of old evidence showing increased risk of death associated with that, but also some more recent data from the SABINA program showing a lot of association between high SABA use and poor outcomes. I just want to focus in on the data from the most recent of those, SABINA 3, carried out in over 25 countries. And there was you could see here the proportion of patients in different countries with high SABA use. And it did vary a bit between countries, but clearly a problem globally. And then in terms of and the group we're most interested in really is the milder asthma patients, the GINA 1 to 2s. What was their SABA use like? Well, actually, 25% plus of people were getting through more than 10 canister per year, and almost half were on 3 or more. So a big problem in terms of high SABA use. And it's not just a trivial matter, because it's also associated. The more SABA that was being used, the greater the risks of severe asthma exacerbations we found, and also, of course, more likely to have uncontrolled asthma. And what is the trial evidence that suggests that it's actually beneficial? Well, in the classical RCT, ICS formoterol, budesonide formoterol as needed, was better in reducing exacerbations than terbutaline as needed, and was fairly comparable to regular ICS. But remember, this is a classical trial, very much enforced adherence with that background therapy and double-blind medicines. If you take a more real-life study, the Novel Start, a pragmatic trial led by Richard Beasley, where actually it's more open in terms of what people are given, so there's not the use of the placebos in the same way, we see a completely different outcome. And here we actually see the ICS formoterol not just better than SABA only, but also better than ICS only, plus SABA as needed. So clearly a very good strategy, both in RCTs, but even more so in real life. And does this all matter? You know, do the exacerbations and things matter? Well, I think there's been a massive amount of data now emerging on the importance of the adverse consequences of OCS or systemic steroids in clinical practice. And this comes from one of our published studies 3 years ago now, that looked at the associations of steroid use, and this could be intermittent or regular, with adverse outcomes. And we can see that those patients receiving steroids were much more likely, whether that's intermittent or regular, like osteoporosis, pneumonia, heart failure, cardiovascular disease, cataracts, you name it. And what was also important is the big costs for those patients are driven by those other conditions. And what we also saw was a dose-dependent relationship. So the more steroids people had, the worse it was. And in fact, even at 0.5 gram to 1 gram, we saw an increased risk of osteoporosis. And at 1 gram, most definitely a big increase, which is just 4 courses in the 7-year period that we were median follow-up period for this study. And also exacerbations matter for many other reasons too, that we've been looking at and seeing. There's a strong association between exacerbations and lung function decline and worse later life adult lung function. And in this piece of work, which we presented at the ATS last year, we saw that patients with more exacerbations start with the worst lung function as measured in terms of peak flow in our UK database, but this is throwing hundreds of thousands of patients at the data here, and that they have a faster lung function decline. And what was important to me was this decline was faster in the younger patients. So exacerbations matter both for the steroid side effects and also the long-term impact on lung function and, of course, the risk of death acutely from exacerbations. And so we've actually seen in GINA now a strong recommendation that we need to be cognizant of this risk of exacerbations and its impact with the steroids on adverse events. What else is GINA saying? This bit is not very, this is the old classical GINA, where the idea being that you went on to regular maintenance. They've tweaked it a little bit, and they've said at step 1, they suggest that you take ICS whenever SARB are taken. And then, so that is a novel tweak. Everything else is very much as it's been before, the idea of low dose maintenance going up to low dose ICS LABA, medium or higher dose, and a classical SABA reliever strategy. But I just want to look a little bit at the concepts here and who they think they're suitable for. And you did see from Sabina that 30% of patients don't take any SABA. So clearly a strategy, a regular ICS will work for some of our patients incredibly well. And there's some patients who may prefer SABA reliever therapy. We also have to recognize that ICS formoterol is not licensed in all countries. So again, we have to be careful with that. The other big thing that I think is really important here, and it's emerging more and more, is that we need to be sure people have got asthma. And I would argue that maybe those patients with non-eosinophilic disease may not actually benefit that much. Other key issues that are brought up is inhaler technique, comorbidities, and obviously a review of adherence, etc. And some of the clinical decision making here, I think, is very important. So we've got those 2 tracks, and we need to be very aware of what is the appropriate regime for our patients. But remember, ICS formoterol can only be used in track 1. Any other long-acting beta agonist as part of a combination is not appropriate. Inhaler technique, and I think is a big issue. And I just wanted to remind people of some of the important errors that occur with our different inhalers and the importance of checking for that. So certainly we found, this is from the CRITICAL study, that the key error with dry powder inhalers is a lack of inspiratory effort. And that tended to be worse for the discus than for the turbohaler. Maybe it's because people don't perceive the resistance. And that's associated with increased risk of exacerbations and uncontrolled asthma. Whereas for MDI inhalers, the main problem is actuation before inhalation. And that's a big problem for our MDIs. And I think we've got to recognize those two key errors and not forget those. And as I said, it's a similar association for exacerbations. Now, what about some of the other things here that are really changing around step 5? And so there's an add-on LAMA, and then the key aspects of referring for phenotypic assessment and the earlier use of biologics. And actually, oral corticosteroids, long-term oral corticosteroids, put down to a very last option, and actually high-dose combinations, also very much sitting now in step 5 too. So who should be referred? Those who've had uncontrolled symptoms or exacerbations despite medium high-dose ICS/LABA, those requiring more than one course of steroids a year. So a real big focus now on preventing overuse of OCS. And obviously those at risk of steroid-related side effects. And then what about what should happen when they're assessed? Well, one big tweak that's come in for GINA 2021 versus 2020 is the recognition that type 2 inflammation is now found in the majority of people with asthma, not just in about half as was previously thought. And we obviously have a lot of targeted type 2 therapy. Of course, ICS does, and then our biologic therapies. And how common is that eosinophilic phenotype? Well, we had a look within the International Severe Asthma Registry, and we put a grading on this depending on different features of eosinophilia. And so those with the highest counts, those receiving long-term OCS or nasal polyps, etc. So we came up with a gradient. And what's clear is the vast majority of our severe asthma patients are eosinophilic. And very few, very, very few, are completely non-eosinophilic. And there's some variation between country, but that may be about smaller numbers in some of those countries when we did this analysis. And those eosinophilic patients, what do they look like? Well, they were more likely to actually have impaired lung function and adult onset asthma, whereas the non-eosinophilic were more likely to be given leukotriene antagonists, for instance. And what does it look like in a broader primary care population? Well, obviously you don't have so much readings of all your T2 biomarkers or the history so well collated. But this is a large study that we did using our Optimum Patient Care Research database and the CPRD database. And we saw that over 50% were grade 3 and only 5.6% definitely non-eosinophilic. So actually the most primary care patients too are eosinophilic. And what was seen is they were more likely to have respiratory consultations and exacerbations of their asthma. And we know this eosinophilic phenotype is more prone to exacerbations, but it was also more responsive to therapy. And then if we think about the long-term OCS, which has really been relegated in GINA, and the reason is that all of our biologics can dramatically reduce the need for long-term OCS from all of the studies. And when we've looked, are there any differences between the different biologics? Well, there's no comparative head-to-head studies, but we've been able to, in ICER, have a look at patients eligible for both anti-IL-5 and anti-IgE and look at their outcomes. We presented this at the ERS this year. And what we saw is that both treatments dramatically improved patients, first of all, but the rate ratio for exacerbations was 0.67. So over 30% greater reduction for the anti-IL-5 versus anti-IgE. We also saw greater reductions in long-term OCS use. So we've got to get these patients in front of specialists, I would argue, and GINA's arguing that. But how many of them are out there? It's going to make a big challenge. We've had a look actually using, again, our Optimum Patient Care Research database in the UK. And we can see exacerbations across all steps, and you can focus in on the GINA 4 here. You can see about 30% of patients have at least one exacerbation, and about half of them having at least 2. So a big population of asthma. And if you look at it in some detail, about 8% of patients look like they've got potential severe asthma, and only, not quite, half of them have seen a specialist in the past or actively. and over half have never seen a specialist. So there's a big need to get these patients more specialist care. I'd like to leave you finally with a little bit of a teaser and to think about a new treatment paradigm. Actually, this is an old concept that we put out actually now with Arnaud Bourdain and colleagues 4 years ago. But the idea of actually understanding people's phenotype of asthma early and actually think about the concept of maybe using biologics much earlier. We saw the problem of exacerbations and steroids, lung function decline, and the idea that maybe we treat people's biology correctly and then tail down their background asthma therapy and may even get to, for many patients, using that as needed. There's a couple of problems, lack of evidence yet, and also cost. But in the future, maybe. So to conclude, I think we've now got a big recommendation from GINA for the use of ICS formoterol controller and reliever, and just as a reliever only in the mildest asthma, but personalizing asthma management. Some people will still want to take regular therapy and should take regular therapy. And remember, that only applies the as-needed concept to ICS formoterol. We have to get more collaboration between primary and specialist care, really get our severe asthma patients properly characterized. I would argue everyone should be characterized. And maybe we actually have to look in the future at much earlier use of biologics. Thank you very much for listening.
Okay. David, thank you. It's obviously a real shame that David couldn't join us, for David to connect with us so we could have a live Q&A session, but unfortunately events conspired against us. So unfortunately we can't have any questions at this point. If you leave any points or observations in the session discussion, we can make sure that we do share that with David and that we can explore it as a mechanism for providing some feedback.